Okay, so what is fundamentally different about common factors and any theories in specific is that when we're testing theories, there's a you're trying to kind of isolate the individual ingredients of, so like the individual interventions, that kind of stuff, to see if they're efficacious. We try to do effectiveness, but as you guys know, the difference between effectiveness and efficacy is effectiveness is like real world, as if you were using it out without any parameters or anything like that. And efficacy is usually in ideal circumstances. So if you think of like a lab where there's things are controlled for, and then effectiveness is like, does this work when shit's all over the place, when people are just living their lives? So efficacy is like a step toward effectiveness. Okay, so in that, we are testing to see, like, do these individual interventions help? And we try to put kind of like, we've tried to quantify some of that, usually in the form of a randomized control trial, RCT. That's kind of the gold standard of how we test different theories. And what is difficult with that is it kind of eliminates therapist variables. It eliminates client variables. So, for example, Sarah delivering solution-focused therapy is going to be different than Lawrence delivering, you're right below me, Lawrence. Lawrence delivering solution-focused therapy. So in RCTs, what they try to do is eliminate or control for all of these variables that common factors researchers say, wait, who delivers it matters. Who they deliver it to matters. So this is my like spiel. I'm building toward what I consider one of the most important pieces of our work as therapists, is what's called transcultural sensitivity or transcultural awareness. I think I may have alluded to this earlier in class, like in an earlier class, but understanding how your social positionality, so all of your pieces of your identity and how they intersect, when they meet your client who has a different social positionality by virtue of them not being you. So even if I'm working with another woman who's 36, who's white, who grew up in middle class, who is bisexual, who is Christian adjacent, all of these things that are the same as me, by virtue of them being another person, they're not exactly the same. So what transcultural awareness or transcultural sensitivity is the understanding of how your social positionality interacts with your client's social positionality. So I really want you guys to be aware of that, you know, I think it's naive to assume that if I am nice and kind and try my best, that it is enough to kind of like overcome or eliminate the reality of who you are and what you represent to your client. So me delivering a intervention is going to be different fundamentally than somebody who isn't me delivering it in regard to social positionality, because all of those contextual factors that affect an individual outside of the room affect them inside the room. So it is naive of me to think that who I am doesn't matter. That if I'm nice and if I'm really good at what I do, that can just eliminate that. It doesn't mean that you're doomed by virtue of who you are. It means that you have to be aware of that. Does what I'm saying make sense? So it's not just about understanding the client and being aware of that. It's understanding yourself and the client and how those two things come together. Does anyone have any questions? Okay. So common factors. I'm going to minimize everybody. I was just looking at the first four of you. So there has been, like I said, many attempts to kind of quantify therapy, which is inherently like a difficult thing to quantify. However, I will talk about the quantification in future slides of, the specific modalities and what are, like, how do the specific ingredients help? But what has been found is in terms of evidence-based therapy relationships, that the therapeutic alliance, our empathy, and us being willing to obtain feedback from the client. So like I've told you before, it can be things like, how are we doing? How was session today? Did I do anything today that felt a little off? Is there anything I could have done differently today? Did we talk about the things that you felt were meaningful to talk about today? So really just engaging in a conversation with your client in an informal way, but there also is something called the session rating scale, which is a formal way of getting feedback that assesses the therapeutic alliance. So if you guys want, I can like post that into Canvas or something, but it's literally just a super short measurement of the client being able to essentially give you a scale or a score of 0 to 10 on 4 different metrics. And a score of 36 or lower indicates probably some issue with the therapeutic alliance. So the goal is to get nearly perfect on all of those from the client's perspective. So these areas are demonstrably effective in promoting favorable client outcomes. And again, favorable client outcomes, as we've discussed today, is really, are they achieving the goals that they set out for in therapy? So favorable client outcomes essentially varies from client to client. And what they also found was that the therapist-client goal consensus, collaboration in therapy, and therapist positive regard for the client, or at least client perceived positive regard from the therapist, were probably effective in promoting favorable outcomes, which, as you can see, these cut across all theories that we've learned so far. So these are considered some of the common factors. So that also ultimately just means what exists within therapy that is not specific to a model. So I won't go over all this. I just wanted to cut some of this stuff for you. So looking at, because again, we live within a scientific world, right? So we try to like measure, what is within session, like what happens in session that stimulates change. And ultimately the theories that we study have their own, or the models that we study have their own theory around this. So that's where the philosophical underpinnings come in of like, this is, as the creator of this approach, this is what I think creates change. And here's the model that I have created that I think makes movement toward change. So looking at the chapter, so again, the common factors theory is ultimately that we cannot eliminate therapist variables. We cannot eliminate client variables. And there are things that cut across theories that are believed to play a really big role in positive outcomes with clients. So the amount of variance, so when we focus on various factors of change, so again, each model has their own theory of change, and they have created interventions and techniques that they believe facilitate change, and the amount of variance they account for. So these are the variables that common factors research has found these are the factors that account for change. So like I said, client variables. So what is their worldview? What is their lived experience? What are their resources? What is their theory of change? Like things like that, resource activation versus problem activation. So again, these are things that exist regardless of theory. So are you talking about and helping the client move toward rallying their resources, or are you facilitating conversation about how terrible the problem is? Securing client participation through things like buy-in, which is helped, or this is facilitated by how warm and empathetic you are with your client. So client participation, engaging them in conversation, creating space for them, validating them. Again, these are micro skills that cut across theories. Rallying their resources, similar to resource activation. Using the client's strengths and the therapeutic alliance, which I'll break down into the three components of the therapeutic alliance. So these are the factors that have been found to be quite influential in client outcomes that are not model specific. So he named this chapter The Heart and Soul of Change because the factors that were identified are believed to be by the therapist or by the writer of this book, and quite frankly, one of the leaders in common factors theory or approach, is the client's resource. He named it The Heart and Soul of Change because that's what he believes makes up the heart and soul of change. It's the client's resources and resiliency in the therapeutic alliance and attaining client feedback. So I've mentioned this before. As you guys, if you look at my theory of therapy, you will see that I live very deeply in common factors. And one big piece of common factors is obtaining client feedback. And as I've said to you before, when you guys have asked questions about like, well, how would we know what somebody means by this? Or how will we know how the family feels about this? I will always tell you, ask the family. How will I know I'm doing a good job? Ask the family, or ask the client, ask the couple. So the client, unfortunately, we do all this work for our clients, but when we do our research, which informs the approaches that we use in practice, we don't talk about the client. So Exposed Psychotherapy's Hidden Assumptions, the heroic psychotherapist, a knight in shining armor, riding high on the white stallion of theory, brandishing a sword of empirically supported treatments, ready to rescue the helplessly disordered patient, terrorized by the psychic dragon of mental illness. So we put a lot of onus on ourselves, and we don't necessarily take into consideration the relationship that is built with the client and seeing them through a strength-based lens. And because we talk about it a lot, we, especially in counseling, marriage and family therapy, social work, we come from what's called a wellness model. We function out of a wellness model, which is essentially kind of the antithesis or the answer to the medical model, which is it is soaked in symptoms and reduction of symptoms, whereas the wellness model is really building on the existing strengths of the client. But so the medical model is where psychiatry and psychology and like our, physical medical healthcare system, that's where they land. And counseling, marriage and family therapy, and social work are still influenced by that. So we still can look at clients as like, we're their last stop. And sometimes clients say that, this is my last ditch effort. If you can't help us, we're going to get a divorce. So sometimes we get a lot of pressure put on us, but just remember that the client is a part of this this dynamic as well. And quite frankly, they have nearly no voice in our research. So client as a neglected factor, the key is your attitude regarding the client's inherent abilities and resiliencies. So I actually read a really powerful article. I think it was in my master's. I can't remember if it was my master's or doctorate, but it was about a couples therapist who, by virtue of what we do, we see people in their darkest moments, right? We see them coming to session and crying the whole session. We see them deep in their grief. We see them struggling with loss, struggling with mental health. And so we tend to see a very monochromatic view of our client. We see them in their struggle. And so in this article that we read, it was a couples therapist who saw this couple that he just they fought all session, they argued, they were like on the brink of divorce, the relationship just really wasn't going well. And so that kind of started to really build his picture of like what they may look like in their home, like that it must be, pretty dark and just difficult, like the energy in the space is probably pretty negative just by virtue of how they presented in therapy. And then he happened to I think they were holding like a garage sale at their house or something like that. And he didn't realize it was their home. And they were like a normal couple, like they had this nice home. They were like collaborating pretty well to run this garage sale. And it really opened his eyes to some of the like kind of biases that he had and how like kind of almost problem saturated his view of this couple was by virtue of having worked with them for, months and months and months and having kind of the same old song and dance in therapy and forgetting that in their day-to-day lives, they were doing all right. So just keeping that in mind of, we see clients in such difficult times that's just one aspect. That's one like subtitle of their story. So just really keeping that in mind. And also looking at clients as the primary agent of change. So expecting that the clients will enhance their outcomes, or expecting that the client is the primary agent of change and expecting that they have inherent abilities and inherent resilience enhances outcomes. So if you expect that is built in to your attitude toward your client. And then again, we've talked about this, and I think this is really in line with postmodern in particular, is listening for and being curious about the client's strengths and competencies, and then really attending to the alliance. So I'll show you some statistics where the process of therapy has been quantified in a way, but attending to the relationship between you and the client is the most powerful factor in outcomes. So this is another, I pulled this from the chapter because I thought it was so poignant and such a beautiful connection to the idea of what's called being a wounded healer. Not everybody agrees with that. I resonate with it because one of the things that you probably have heard from, people in your circle, and then I'm confident you will hear from clients, is by virtue of you being in this field, you probably have your shit together. You've worked through all your difficulties. You probably have a great relationship with a partner and beautiful relationships with your parents and your family of origin, and you and your siblings are best friends, so it's this very like idealistic, not realistic at all, reality of where we're at. So you kind of get like put on this pedestal in many ways, and you're sometimes held to a different standard just by because what we do, this is a job. I think that's important to remember. This is a job that we do. It doesn't define us. It's something we do that we find worth in. But as people, we're separate from that. So the idea of the wounded healer is that we also have been through stuff and are currently going through stuff. One of the things that we commit to by being in this field is we are committing to investigating ourselves and continuing to question and explore biases, stereotypes, blind spots, areas that that are not helpful to us in our quest as a therapist, but likely we've internalized by virtue of how we've been socialized. So we have a commitment to always exploring that. That's the Self of the Therapist work that's woven into your training here at Alliant, as well as a commitment to self-growth and being willing to work on stuff. And so, the hope is that you're walking the walk, that you are engaging in your own therapy, whether that is with a professional, whether that, whatever provides you a space to process, but that you're willing to engage in that. So the line here is to resonate with despair, but refuse to succumb to it. It requires that you listen to the whole story, the suffering and the endurance, the pain and the coping, the desperation, and the desire for something different. So just remembering that humans are complex. We usually get the suffering, the pain, the desperation. And as we know, with something like problem saturated narratives, our clients can stay there, but it's our job to also see the resilience, the beauty, the complexity. And it's such an honor. Like, and I know this is a cliche, but I sincerely feel this way, that strangers let us into their world in the most intimate way that you can possibly allow another human into it. And that is such a privilege. And I just really want you guys to remember that, that we are entrusted with some of the most vulnerable and difficult expressions and stories and experiences. And that shouldn't be taken lightly. But we also need to see the clients as capable. So here's the how the therapeutic alliance, or the percentage of the common factors, kind of plays out. So if you look at models and techniques, that accounts for 15% of outcomes. So the specific ingredients of the theories. Expectancy basically means like, do I believe that therapy will work for me? So that attitude coming in of believing in the process, having that buy-in. And then the relationship factor. So these common factors, the quality of the therapeutic alliance that you have with your client accounts for nearly a third of outcomes. The biggest factor is stuff that we have no control over. Again, this is where the client plays such a big part in their own change of the client and extra therapeutic factors. That accounts for nearly half of outcomes. How they quantified it, I'm not going to get super into that. That will take, we could do a whole I took an entire semester on common factors. So that's how much we could talk about it. So the therapeutic alliance, go ahead, Joby.
Sorry, what's the difference between expectancy and the client and extra therapeutic factors?
Yeah, so client is like, it's kind of like resources. So the client and extra therapeutic factors is like what's going on outside of therapy. So, what the quality of their relationships, what they're doing outside of therapy. The client it's like things like relationship, their demographics, the intersections of their identity. And then expectancy is specific to their buy-in in terms of their belief in the process of therapy and them believing that it will work. Does that make sense?
Yes, thank you.
Sure. Any other questions so far, guys? Okay. So the therapeutic alliance has 4 components: how the client is impacted by the relationship with the therapist, how the client works collaboratively with the therapist, how the therapist is able to empathically engage and work with the client, and how the therapist and client agree on goals of therapy. That is this right here. Nearly a third of outcomes are affected by these 4 components, which again, not theory specific. So theory relationship factors are the second most, therapy relationship factors are the second most influential component that leads to client change. And the relationship, also known as the therapeutic alliance, is twofold: the client's relationship with the therapist and the therapist's relationship with the client. So it's a bi-directional influence. So with the alliance, there's essentially 3 components. Is the relational bond between you and the client. So how does the client perceive your empathy, respect, your genuineness? And then you're figuring out how the client values empathy. So for example, so when we think of empathy, we usually think of saying like, I see the pain when you talk about that. I resonate with that in some way, or, that you're reflecting what you're seeing in that. This is really difficult. Thank you so much for sharing, holding that space. Sometimes people find that annoying. So understanding, so the indicators here are how the client reacts to your empathy. Like you might get somebody who like rolls their eyes or like kind of does that. And so as you're delivering empathy as you value it, right? Because when we think of empathy, we have our own definition of what that is, that may not be what the client needs. So sometimes clients need you to be like, that was such a messed up injustice. They want somebody to kind of get in there and resonate with them or like be passionate with them. Whereas maybe your idea of empathy would be, that sounds just so difficult to manage. And, even listening to my tone, you can hear that like, that's my kind of default into empathy. So just, really being aware of how the client responds when you're delivering empathy. Agreement on goals of therapy, as we worked on today. This is something, in my opinion, that should always be co-created. Your client should have full access to their treatment plan and be able to be like, I like that. Nah, let's do something different. Like it should be your co-pilots in this. And then agreement on the tasks of therapy. So what you're talking about in therapy, how often you're meeting, what is the policy on cancellations? I don't know if I can give you 24 hours notice. I work shift work, or, I'm still figuring out custody with my ex, things like that. So like, that's all part of the alliance in allowing them to have some say in that too. Is it okay? Can I do 10 hours prior that, so then I won't get charged? And then what the payment is. So that's something that I think, money is something in our society that's so like taboo to talk about. And sometimes that's not clear in the consent form. If you look at Psychology Today, which is where like mental health professionals have their profiles, and where they have like a little blurb about them, sometimes they don't list prices. I don't really get that. Like, I think you should know what you're getting into, but being very frank about that. And quite frankly, you might have clients who, in the middle of their work with you, where they've been paying you a specific amount, you've agreed upon it, they maybe lose their job, or I don't know, get hit financially in some way. Like, are you willing to work with that client with money and maybe go on a payment plan or reduce your fees temporarily or something like that? These should always be topics that you're open to discussing with your client. So how do you enhance the relational bond? You listen. What it means by staying close to the client's experience is those reflective statements. What I'm hearing you say is this. Did I get that right? Asking questions and that are genuinely curious about their perspective on something. So staying close to it just means that you have an understanding of it because you've elicited more information. You've reflected in an accurate way where the client really believes like they are understanding me. Be likable, friendly, and responsive. Again, we have all our own beliefs on what this looks like and how we do it. It's important to incorporate the client's perspective into that. Because remember, thinking about the relationship, it's the client's perspective or their perceived relationship with us, and then our perceived relationship with them as well. So monitoring client responses, I already kind of alluded to this a little bit, but you might find that, because sometimes we get passionate about stuff. Like, we're not going to be perfect at this, where you pick a piece of their story and you kind of run with it because you find it really interesting, and you were, in the heat of the moment, and you weren't necessarily really checking in with them, but you thought, oh, this is something we need to unpack right now. And slowly, as you're like passionately asking questions or maybe self-disclosing or something like that, you're watching the client like sink into the seat and like cross their arms and stuff like that. So they're non-verbally indicating to you, because remember, the therapeutic relationship is inherently unbalanced. It is we inherently hold a position of power. We're the professional. They're seeking a service from us. We hold power. They're looking to us for expertise and to help them in very vulnerable moments. So sometimes you'll find that clients aren't vocal in terms of like constructive feedback. So you have to monitor through nonverbals, and nonverbals is how we communicate most of the time anyway. About 60% of human communication is nonverbal. So you're going to watch them. So you might also, ask kind of a random question, or just, a curious question about their paternal grandfather. And then you see them go, oh, my grandpa, they lean in and they get excited. Then, you're going to follow them there because it's something that's meaningful to them. So you're watching their body language and how they react to the things that you are bringing up. You might be, diving into some trauma and you're watching them kind of shrink into it. Check in. How are you doing? I'm getting really flooded. I'm really overwhelmed. Okay, let's pull it back. So just being attuned to how the client is responding to the content and the process of what you're doing in therapy, being flexible and accommodating, exactly what I just said of like, if a client is saying like, I can't go there, don't go there. And just, again, flexible and accommodating is in the session. And again, it can be, given some stuff that happens outside, again, like cancellation policies, payments, flexible and accommodating in that way. If they want to bring their partner into a session, but you've been working with them individually, being open to that. But again, the one thing that I will say about payment though, is that this is our job. So if you have a caseload of 20 clients who hit a financial crisis all at the same time, you still have to put food on the table. You still have to pay your mortgage. You still have to pay your rent. So please don't self-sacrifice to the point where you like lose your business, or you're doing like 50% of your client caseload is pro bono and you're like the main source of income for your household. You've got to take that kind of stuff into consideration. We are not a like nonprofit service. This is what we do for a living. So don't forget that either. You've got to value what you do and demand payment for that value. And then validating your client, again, empathy, unconditional positive regard, checking in with the client is the way that you are expressing empathy. Does that align with the client? Like, how do they react to that? So another thing with common factors, so we talked about this, I think it was week 2 of our semester. So eclectic, remember, is not really having a theoretical foundation or a philosophical foundation. It's just kind of like session by session, trying different things without a cohesive justification or rationale. Like you don't have a big picture kind of theory or model that you're working with. So as I said, in week 2, if y'all do any sort of self-promotion, any sort of advertising, have your bio out there anywhere, please don't use the word eclectic. I know it's semantics and it doesn't mean the same thing to everybody, but to me, it literally means I know techniques and some theories and like I'll use them, but I don't really have an overall game plan. And I don't like that. So selective borrowing is honestly what I do. I have like a foundational theory. I kind of have two, I would say 2 foundational theories, which is feminist and common factors. And then the selective borrow. So I have an overall philosophy. I have an overall framework. And so I can tell you exactly what my game plan is, but I'm also pulling interventions and techniques from multiple approaches that I believe are cohesive in the overall goal or achieving the overall goal, what aligns with my overall theory of change. And then integrative is you're taking essentially like 2 theories in their totality and you have found a way to integrate them. Multidimensional family therapy is a integration of 2 existing approaches. Cognitive behavioral couple therapy is an integration of 2 existing theories. So these are just kind of fundamental ways that you can integrate theories. Okay, sorry, I forgot that I had a breakdown of each of these. So eclecticism, when you draw from a variety, the problem lies in inconsistency. It's like sampling techniques. Sorry, that should say from diverse approaches without a conceptual focus. And then you can kind of change models midstream. It's kind of like changing maps when you're going somewhere. You probably will still get to the destination, but it's not really effective. It's not the best route. So I'm not a fan of eclecticism. Selective borrowing, like I said, it occurs when you borrow different techniques and combine approaches based on one solid paradigm. To do so, what you need to know first is your theory of change, your theory of human behavior, your worldview. So like I align with feminism because that aligns with my worldview. And it is an approach that has techniques that I believe in, I have allegiance to. And we'll talk about that in terms of research as well. And then integrative models. So these are comprehensive, theoretically inclusive. These have two distinct approaches. So narrative solutions approach, the integrative couples therapy. These are two approaches that have been essentially created into a new approach, but they are intricately integrated, taking the theoretical foundations of both and mending them together. Before we take a break, I'll stop talking for just a second. I'll look at all of you. Joby, is that your hand up new? Sorry, I didn't see it. It didn't come across no, it's just been up.
No, yeah, sorry.
Okay. Sorry, I was gonna say, I didn't see it come across so when you think of like last semester and what we've covered so far this semester, are there like two theories that you think for yourself make sense to put together? So for me, like narrative and Bowen makes sense.
I don't know if this was a rhetorical question or not.
Oh, it's not. I'm interested in some participation. Okay. You guys like CLS, don't you?
I liked it.
It's a good posture to have with clients. I appreciate that. It does have lots of, well, I was just going to say something kind of silly. I was going to say it has common factors element, but literally all of them do. Any other, like, can you see yourself using, contextual and IFS? Oh, I like that. That's a great one. Who said that? Jocelyn. Interesting. Oh, Yasemin, you're going triple. IFS, Bowen, and feminist. All right. Again, if you can, so remember, true integration is knowing back and forth that approach. So you're understanding the philosophical underpinning. So again, this will take years for you to come to. So right now it's just kind of what am I interested in? Does this align with my worldview? When I think of self with the therapist stuff, what comes up for me when working with this theory? Jocelyn.
So I saw a lot of people put like a third part, which would be like feminist. Because I'm tempted to do that too, but I don't really think of feminist as like a third theory, more as like a lens or approach sense. So I wouldn't really like, I don't know if that makes like, if that is a thing, would you still have to consider that as like a third theory of, or would you consider it more of like a lens?
So usually what people do, so exactly what I did with my approach is it's considered feminist informed. So it's not necessarily pure feminist approach, but you are looking at things like power dynamics, social inequities. Yeah. You are addressing things like social positionality. That's an integral part of how you do that. So it would be like, for example, it might be with Yasemin, it might be IFS and Bowen with a feminist lens, because IFS doesn't necessarily bring in that contextual piece. Bowen, not so much either, but if those are important aspects, then it would be a feminist lens looking at those two.
Oh, thank you.
Cool. So yeah, just curious what y'all think, if you've thought about how two might marry together. All right, let's go ahead and take our last break and come back together at 5:12. All right, everyone, let's come back together. I forgot to stop recording that, so to get 10 minutes of looking at black squares on here. All right. Any questions, any comments, anything so far about what's been covered with common factors? So all that I'm sharing with you may lead you to believe that, well, why do we learn theories if they only account for 15% of outcomes? So remember that one of the aspects of your theory is the concept of allegiance, like how much you believe in your theory's ability to promote change, which ultimately increases, your desire to work well with it. So looking at things like common factors, which I think can be sometimes erroneously diluted to just like the bond, the goals, and the tasks of therapy. It's more than that. As you know, it's worldviews coming together. It's empathy and compassion and all of that kind of stuff. But adopting a common factors approach doesn't mean that we don't need to know models. So I don't want the takeaway from that to be like models don't matter and we just have to focus on like building a really strong therapeutic alliance. As you know, that's only a third. There's other stuff that's going on. So when you look at all of therapy, like I said, there's the client, the therapist, the therapeutic relationship, expectancy, and then non-specific treatment variables. So these are essentially like we talked about, kind of the extra therapeutic stuff where when we think of the treatments, when we think of the specific techniques, interventions, that it's stuff outside of that. So when you're looking at, commonalities amongst conceptualization in theory. So remember what we're covering now, they all fall into a postmodern philosophy. What you covered last semester was a combination essentially of modern and systemic. So if you remember kind of those charts that we covered earlier in the semester, so you can see some of the conceptualization and approach similarities. So the question here, for example, so I think Amy, I think you identified what structural and narrative as your two, or structural and like a postmodern. So there are, because I think sometimes people think that if you pull from pull an approach or a model from the modern philosophy and an approach or model from the modern or postmodern philosophy, that they're inherently incongruent. And I disagree. So when you look at structural and narrative, for example, they both have a relational conceptualization. They both treat the family and not the individual. And they talk about an expanded therapeutic alliance. So in structural, you're managing multiple alliances. You have your alliance with each individual member of the family. You have your alliance with subsystems. You have subsystems, the relationships amongst the individual within subsystems. You have across subsystems alliances. You have your alliance with the entire family. Like that's one of the things that I think really differentiates us as clinicians, is that we are simultaneously managing multiple alliances, whereas in individual therapy, for example, you're managing one. So I think that fundamentally makes what we do more complicated. So then the other thing that we read this week was the dodo bird verdict is alive and well, mostly this article. So very similar, again, kind of just driving home the point of the importance of, not overlooking these common factors. So essentially the dodo bird verdict is that essentially like, what's it on? Is anybody familiar with the show Whose Line Is It Anyway? It's like something and the points don't matter. Does anybody watch Whose Line Is It Anyway? What was that?
I was gonna say, I think that's it. It's like everything is made up and the points don't matter.
Yeah, everything is made up and the points don't matter. That's the that's the tagline. So when there was a comparison of the active ingredients in specific models, they found a non-significant effect size. So again, what we tend to do in our research is we compare a model to no treatment, or we compare a model to what's considered treatment as usual, which is usually just like psychoeducation, or maybe something within community mental health where the treatment is pretty disjointed. You know, you're working with multiple therapists. Like there's all these factors that aren't really accounted for. But when you compare one approach to another, usually what you find is outcomes are not significantly different. And then when you correct, again, what I talked about in therapeutic allegiance of like, how much does the therapist believe in this approach? So if you have a therapist who is like trained in emotion focused therapy, if you are Sue Johnson, so because emotion focused therapy has the most empirical evidence of any approach. So it's touted as a evidence-based practice and an empirically supported practice, but evidence-based is kind of like a higher level than empirically supported. Lots of research on it. And so if I am Sue Johnson, I created this theory and I'm testing the effectiveness or the efficacy, usually the efficacy of this approach to solution focused. What do you think I'm going to be more enthusiastic about? Probably going to be biased toward the approach that I really believe in. Or if I am a cognitive behaviorally trained therapist and I believe that change happens through cognitions and behavior, the interaction between affect, cognition, and behavior, and then you give me narrative where I'm like talking about deconstructing dominant narratives and social context, when I think that it's focused on the individual and that kind of stuff doesn't matter, what do you think I'm going to put more effort into? So when these effect sizes are correlated or corrected with therapeutic allegiance, their differences are reduced even more. So just so you know, effect sizes, it's a type of measure of the degree of association between two variables. It ranges from -1 to 1, and it's either like an inverse association or positive association, I think is what the other one is called. And so you want it to be closer to 1, and the closer it is to 0 just means that there's no difference. Okay, so there was a theorist who hypothesized that different psychotherapies would have major ingredients in common that would lead them to have small and insignificant outcome differences. This was a hypothesis in like I think it was 1943 when Rosenwein hypothesized this, and they were right. So ultimately, the types of treatments do not differ much in their main effective ingredients, but the therapeutic alliance, the opportunity to express one's thoughts, and gains in self-understanding were all identified by clients as important things. So it's interesting when you look at some of the qualitative research, when we actually do ask clients, like, what was helpful for you in therapy, they're very rarely going to say, you know what, my therapist asked the miracle question at just the right moment. They delivered the intervention of enactment flawlessly. It's usually I felt heard, I felt understood, I really trusted my therapist, I felt like my therapist valued my opinion, I felt safe. Like these are the things that are being identified by clients as meaningful to their progress. Because when you think of essentially, what is it? 15% expectancy, 40% client and extra therapeutic variables. If 55% of outcomes are essentially completely out of our control and in the hands of a client, like they are accounting for over half of outcomes. So if they come in and say, like, I just felt like I had this really collaborative space to process what was going on, they're doing 55% of the work outside of therapy anyway. So what we're doing in the session doesn't hold as much weight as what the client is doing. And again, we very rarely hear from what the client thinks facilitates change. We come up with all these theories and we're like, I wonder if it works. Let's ask the clients. So like I said, the researcher's allegiance to treatment influences the effect of that treatment. So one of the things, if any of y'all want to read it, I did a meta-analysis on dropout in substance use treatment. And ultimately, when I was doing the meta-analysis, it was kind of difficult even to compare treatments and to quantify what may be, or to hypothesize and actually quantify what may be contributing to participant dropout, because how the researchers shared their results were really inconsistent. So we would have, you know, if we were talking about like client demographics, we might have that in like 75% of our studies. We might have like access to resources in 30% of our studies. So it was difficult to actually even do an analysis because the information that we had from each was inconsistent. And that was one of the things that was found in the research regarding specific treatment models, is that clinical and procedural difficulties in comparative treatment studies, meaning that they were inconsistent. There's no standard for what you should be reporting on. It's kind of up to the researcher to determine the story that they want to tell. And many times it's even difficult to compare models or to compare treatment factors, because it's like comparing apples to oranges in terms of just not having the same data to be able to compare. So I hope that that makes sense, is that there's no standard in like, okay, so this is what we need to report on in order to effectively and accurately compare what's going on. We don't have a standard for that. So I think that if meant is are. Interaction between patient qualities or client qualities and treatment types. So again, if you have, for example, like, so let's say, again, you are a diehard fan and use emotion-focused therapy every second you can, and you have a very logical, intellectual person. If you're using emotion focused on a person who doesn't value emotions or who doesn't see the point or role of emotions, that's going to inherently affect the outcome. But like, how do you measure that is the question. So it is like, that's where the factor of agreement upon tasks, agreement upon what's collaboration within the therapeutic relationship, that matters. We are in a seat of expertise in terms of techniques, but it doesn't matter if we're delivering the interventions perfectly, or we are so bought in and we have so much allegiance to what we're doing, if the client doesn't find value in it. And that's when I talk about the client being neglected in that, that's what I mean, is we don't talk to clients and say, you know, how did you feel about this? Like, what was it about this technique or whatever that helped? We don't really ask that. So some other possible explanations for the lack of effect size or the lack of significant difference is that certain therapies may be more effective for certain groups of people. There's a need for comparison of long-term therapy. So as we know, in the managed care model that we're in, and essentially, and quite frankly, in the like realm or in our system of randomized controlled trials, the goal is to get as much data in as little amount of time as you can. So there are certain approaches, I would argue things like existential therapy, or quite frankly, like narrative therapy, that just inherently takes a little bit more time. So these aren't really evidence-based practices, but that doesn't mean that they don't work. They don't fit within the confines of what we consider evidence-based, because it's difficult to measure change in a treatment that's meant to be, or has been structured to be, a little bit more long-term, something like collaborative language systems, and be like, well, what was the change in 6 weeks? Like something like solution focused or cognitive behavioral therapy fit into that model. Emotion focused therapy is a time limited. It's roughly between 9 and 12 weeks is kind of a standard delivery time for emotion focused therapy. Again, I just named 3 evidence-based practices where when we have more long-term therapy, it just doesn't fit into that model. So we have difficulty building evidence with it in the how we measure it today. And then there's comparing other aspects of the client's change beyond the symptom measure. So this is something that I've talked about in terms. So again, my postdoc was specifically with cocaine use disorder. And one of the things that I added to our protocol was a qualitative piece. So when we think of outcomes specifically in substance use treatment, we talk about frequency of use, amount of use, and it's very like amount of time of abstinence, and it's very use based. But again, just as I kind of started this lecture today, clients are more complex than that. Like addiction for this individual is one aspect of their life. It's potentially an aspect that has blown their life up, but it's one area. And so if all we do to measure success in substance use treatment, for example, is just decreased use, that doesn't necessarily mean that their life has improved. So what I did in my postdoc was I added a qualitative component. I added an interview asking about things like relationships, employment, living, like how is your living situation? Has that changed at all? Familial relationships, romantic relationships, sense of self, belief in change, sense of hope. It's not captured if we just look at use. So it's the same, to me, it's similar, if, bringing it back to MFT, is that a successful marriage is if you've been married for a long time. We know that's garbage. And we know that just because you've been married for 25 years doesn't mean that it's been the most beautiful, fulfilling, loving 25 years of your life. It could have been, pretty solid for 5. In the last 20 years, I've been miserable, or I've been, hiding the intimate partner violence that's been happening. I can't leave because I can't afford to live on my own. So it's these metrics that are so limiting and it doesn't give the full picture. So evidence-based practice and empirically supported treatment, just wanting to, again, as you guys are moving through the program and you're doing more research, I think it's important for you to understand the difference between these. So evidence-based practice, as y'all know, I am inherently skeptical. There's a lot of assumptions that are made when we dub something, label something evidence-based, is that in the research, a homogeneous client population is studied. Again, does that translate to effectiveness? Hell no. They're homogeneous in a specific way. And as we know, generally that means racially homogeneous, socioeconomically homogeneous, many times sexual orientation homogeneous. And that just isn't what therapy actually looks like. The clients are randomly assigned to a treatment or no treatment. That's fair. It's also, as we know, not a great way to, so we know that some therapy is better than no therapy, that like anything provided in terms of a space for talking about your issues is better than nothing. So like, what does that really matter? Really, therapists are carefully selected, trained, and monitored. Again, what you guys will learn in your time in the field is that there are super crappy therapists out there. The inherent level of talent in this field varies greatly. So when you do an RCT, you usually have these like meticulously trained, particularly selected. So when that translates into real world clinical stuff, you're not giving the techniques into the hands of necessarily very skilled or competent therapists. So there's that disconnect right there. Specific interventions are prescribed. Again, you know, if you work at all from an integrative model, because you have a protocol, you have what's called, you have a manual, evidence-based practices or randomized controlled trials. You have to have a standardization which has the ability to be replicated. It's the component of what's called fidelity. So I stick very closely to the manual so that it is demonstrated and that I am able to prove that I gave the exact same therapy to all of the people. The treatment is designed for a specific disorder or diagnosis. Usually treatment is brief or a fixed duration. As we know, that doesn't really translate to real practice. Treatment manuals are employed to ensure all receive the same interventions. Again, that's the aspect of fidelity. The process change mechanisms are articulated, clear goals are delineated, multiple outcome measures are specified, and follow-up procedures over extended periods are employed. So this is just the process of what happens when proving or investigating what you want to become an evidence-based practice. So essentially anything can become evidence-based. You just have to have the funding, the personnel, the buy-in, the ability to test it. So the definition of evidence-based practice, it refers to the therapist's way of choosing what treatment to offer. And then empirically supported treatment, very different. It refers to a specific treatment model shown to meet certain standards. So empirically supported, I think, is the next one. Actually, let me go here. Empirically supported, unfortunately, it's based on the medical model. So again, it posits that specific ingredients are critical to the outcome of therapy. Whether ingredients are administered to or received by the client are considered more important than the therapists who deliver them. So again, it's very specific to the model. So if you think of the medical model, you don't really have to, in many senses, take into consideration specific patient factors. So when you think of certain surgeries, it's a standard surgery because our organs are pretty similar. You're not necessarily taking lifestyle into account. You're not necessarily taking all of these aspects into account. And quite frankly, the belief is if I train the doctor well enough, anything about them doesn't really matter. Their personality characteristics, their personal skills, stuff like that. If they know how to do this thing, that's all that matters, because the thing that they're doing is important, not the person who's doing it. So the designation, this is important too, that the designation is solely based on the research literature on that model and its use with a specific problem. So an empirically supported treatment. So for example, marital distress, behavioral marital therapy is specifically empirically supported with marital distress. So behavioral marital therapy may not be useful with something like couple communication. It's specific to marital distress. So we'll be learning about multisystemic family therapy, that it has been empirically supported specifically with juvenile delinquency. CBT is empirically supported with substance abuse and depression, but it also has kind of risen to the level of an evidence-based practice. So then looking at evidence-based practices, the goal is to behave as a research-informed clinician. So the hope is that, the research translates to the clinical application. And it draws from the research, but it's not beholden to it. The treatment decisions are made by considering at least a few constantly evolving and changing factors. So evidence-based, again, is a higher level, but it still doesn't necessarily take into account client factors, therapist factors, a ton of contextual factors. So it is specific to the model and its applicability, regardless of who delivers it, regardless of who it is delivered to. And I think that's it. That's all I got for you guys today. Questions, comments? Anything about the research? My hope for you sincerely is that you stay critical of the research that you read, that you look and see, again, who is delivering it? Do they have a vested interest in the narrative that is being shared? And again, I don't want I don't want to sound like a conspiracy theorist that all data is skewed, that there's no real truth, that everything is just has some agenda to it. But I do think it's important to keep that critical thinking cap on all the time, in terms of just like how the research is generated, of staying willing to question that kind of stuff. Anything? Oh, go ahead, Kiho.
Yes, I have a question. So how these common factors address the issues of like race or spirituality or gender, social class stuff.
So
Because-
remember, it's not a model in and of itself.
Oh yeah.
It is what is a thread with all approaches. And ultimately what it's saying is that the client is important in this equation. The therapist is important in this equation, that we can't just eliminate that and believe that the interventions that we're delivering are it, that they're in isolation. So essentially common factors, how it would address that kind of stuff is it would be interwoven into an existing treatment or into an existing model. So you would use, you would privilege the therapeutic alliance within the feminist model.
Oh, so you mean like we have to use like actual like model, so we can use like other like theory, right?
Right. So theories matter. What they're saying is what we found is that the therapeutic alliance and the relationship you have with your client affects outcomes to a greater degree. So put stock in that, pay attention to that. It's not just, again, that you delivered the miracle question beautifully, that you asked the perfect scaling question, that can't be in isolation from the kind of relationship and the collaborative nature that you have with your client. That's ultimately what Common Factors is saying.
I see. Thank you.
Yeah. Any other questions or comments? What do y'all think of Common Factors? Nicole.
I felt like the whole time throughout the presentation that like Common Factors is just a reminder, like don't lose sight of the important stuff. Like, yes, the theory is super obviously important to give us the framework, but like don't forget about the reasons why we're doing this and who we're doing it for.
Yeah, and remembering why you chose the theory you chose, that you are a factor in that too. And your belief in that is important. Yeah, I would argue that it is like attending to those micro skills. But again, like we've talked about with postmodern, it's a positionality. It's how you are, how you choose to be with your client, which I think is sometimes kind of frustrating because theories they give you a structure, they give you parameters. Okay, I have nothing else for you today. Please remember, I will give you a deadline of, what is 2 days from now? The 18th, what's 7 days from that? The 25th. I will give you until Friday, the 25th, to pitch me your ideas for the extra credit assignment. And I will essentially probably give y'all a list to choose from. Again, my hope is that it's meaningful, it's helpful, it's useful, and it's not just an assignment to get 15 points. All right. Thank you all so much. Have a great day. We are hearing from, who's presenting next week? Piola and Christiana with CBT. All right. Have a great night, guys.
Thank you. Good night.